For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up, Season 2, Episode 34, our coverage of Day 3 of Digital ILC 2021 starts now.
This week, close to 10,000 stakeholders from across the global hepatology community are convening virtually for the Digital International Liver Congress 2021, a 4-day meeting with well over 100 sessions on a broad range of liver-related topics. Join hepatology researchers and key opinion leaders, Dr. Manal Abdelmalek, Dr. Ken Cusi, and Dr. Ian Rowe, liver wellness advocate Louise Campbell, and pricing and forecasting guru Roger Green as they discuss some of Friday's key presentations and messages today on the Surfing the NASH Tsunami podcast.
So the first thing you just learned that's different than a typical recording is that if we make a verbal stumble now, you will hear it. I'll clean that up by the time it goes up tonight, but there are at least 10 or 15 people in the world who know that I just screwed up my opening. Well, 15 people in the world who know I screwed up my opening. I trust you're going to keep my secret forever on this. So Day 3 ended about 90 minutes ago. Or the last session of Day 3 ended 90 minutes ago. There are, I think, some Meet the Experts that are going on in the industry seminars. But other than that, we're pretty well done for the day. And it's been, I think, a fantastic and exciting day and a fantastic and exciting meeting so far. Everyone I talked to is tremendously energized. Even all of us Americans who've been getting up at outlandish hours in the morning to be part of it, except for Dr. Cusi, who's got his priorities straight. So with that, let me just start with our panel for today. I'm over where I am on the screen. Next to me on the screen, I don't know where anyone else's screen is Dr. Manal Abdelmalek from Duke University. Manal, how are you today?
Oh, wonderful. Thank you for having me, Roger. It's a pleasure to see everybody again, and I'm delighted to be here.
Well, since the next major meeting is going to be hybrid, I'm assuming we're all going to be in Anaheim together, and we'll actually be able to do this all in one room, which will be a different kind of fun experience. Next, Ken Cusi. It's actually, to my embarrassment, the first time Ken's ever been on this podcast, but I'm thrilled to have you with us today. Thanks.
I'm really excited. I mean, always trying to give my endocrinology perspective as I'm an endocrinologist at the University of Florida in North Florida.
And then I don't know why we put the Americans on the top and the British on the bottom. It doesn't seem fair to me that we did that. But right between Manal and me on the bottom row is Ian Rowe. Ian, how are you today?
I'm very good, Roger. Very pleased to be here, enjoying the digital format of the meeting again.
For those who don't know Ian asks a lot of questions. In fact, the first session I got to yesterday, there was an Ian question in it in about 10 minutes. I said, boy, I feel at home. This is very good. It's a good question, too, not surprisingly. And then to Ian's left or right, depending on how you want to look at it, is Louise Campbell, who's been kind of my sidekick since episode 3. Louise? 3, 4, something like that?
Yeah, I think it's 4 and took a day off yesterday, so nice to be back.
I was quasi-lost without you, but somehow we muddled through. And one secret just for everybody is that most of us have never been, well, Ian and I, or Louise and I, and other folks have just never been face-to-face in the same room. This podcast started after the pandemic. I only started getting seriously involved in fatty liver disease around the time of the pandemic. So many of us don't really know each other. Well, we know each other reasonably well, but not in person. So Ken, do me a favor. Let's take a minute and tell our audience a little bit about you beyond being kind of the preeminent fatty liver endocrinologist and being at the University of Florida. A little bit about yourself and how you got here. And then one thing that they wouldn't know if you didn't tell them.
You wouldn't know where my accent comes from. I was born in Allentown, Pennsylvania, but my family is from Buenos Aires, Argentina. So I traveled back when I was young, did medical school there and my internal medicine residency. But then we had an exchange at Baylor College of Medicine in Houston. So that's where I did my endocrine fellowship and spent a long time at the University of Texas in San Antonio. It has a big diabetes program there. And actually a gastroenterologist there said, hey, what do we do with these people with elevated liver enzymes? And I said, I don't know. Let me look at the literature. This was 20 years ago. And then we said, well, why don't we give them a diabetes medication? And so we looked at rosiglitazone and Pio. Pio had better lipid lowering, better probably cardiovascular profile. So we did a little study with pioglitazone and it worked. And then I got pulled by all this, NASH mafia, Manal and all of those, which I learn all the time, a lot of stuff. And I began looking at the metabolic angle of NASH. So now, since 2011, I'm the chief of endocrinology and diabetes at the University of Florida in Gainesville. And we have a program where we have some basic lab looking at some mice models and looking at mechanisms in humans and doing some clinical trials and an NIH grant to screen and then find out what goes on outside of liver clinics with NASH.
That's great. Do you ever get back to Buenos Aires anymore?
Well, with COVID, it's been a little bit challenging. Argentina nowadays is one of the hotbeds, but in general, I go a couple of times a year under normal circumstances. Yes, got lots of friends and family.
Fantastic. And no, I would not have known that was an Argentine accent. So that's great. And I'm only hoping that Lionel Messi gets to win one major trophy before he retires.
Don't tell me. It's been, I can't sleep at night and still wake up with the nightmare of that final against Germany last World Cup. So if we can get back on track here.
Louise is a profound Liverpool fan. Ian is a Newcastle fan. I'm a Tottenham fan. So at least you're in good company with soccer fans today.
Yeah, there are a couple of Argentinian players in every European team. I think in Liverpool, I don't know. I haven't followed that closely. Are there any now or?
No, I can't think that there are at the moment, but we'll be taking on Germany, and let's hope we do a little bit better than your last.
Yeah, that's always a tough one. My dear, I have a lot of good friends in Germany. They always have good competitive teams. So
I'm glad Sean's not on the podcast tonight.
Jorn was on last night. It was late for him. He was great, but it was late. All right. So with that, why don't we go on to the first thing we're going to do, which is our icebreaker question. What I'd like to know is one thing each of you have heard today at the conference that caught you by surprise, or that you hadn't thought of the way you thought of it, the way it was packaged today. Brave one, go first.
Well, so I'll go first today. It's Ian here. The thing that's really struck me today and in previous days is the real focus that there is on lifestyle intervention. We've said and continue to say that the mainstay of treatment is diet and lifestyle, but this is the first time I've really seen action to that focus. And I guess that we're going to talk about that as we go through the podcast today. But that's been a real highlight for me.
I'll jump in, and I was kind of talking and alluding to this. What really struck me about today and even in the days prior, and it really, really was driven home with a postgraduate course, is the element of nuance and elaborateness of lifestyle and the epigenetic modifiers of this disease that really transcend the primary discipline of our specialty, GI and hepatology and even endocrinology, where we are going to have to really integrate behavior modification, addiction medicine, and broad patient advocacy and education groups. I mean, I showed one slide, for example, that I don't think many of my patients even recognize there are 8 to 10 teaspoons of sugar in a sweetened beverages, and that as little as 7 sweetened beverages a week will incrementally increase their risk of NAFLD by 56%, let alone their fibrosis risk. We have so much work that this postgraduate course and this Congress at large really brought up straight and center lifestyle modification, the environmental risks and exposures, and in my mind humbled me a little bit to say, how can I possibly address these issues in my limited scope of work as a hepatologist?
Yeah, along those lines, I would say I was impressed by how I was in this symposium where we presented several drugs for NASH with a metabolic side, how the emphasis has expanded. So I always get into friendly fights with my peer endocrinologists because they don't consider the liver very much. But I was also very happily impressed today how the liver community is embracing more the cardiometabolic risk, looking what is the effect on drugs tested for NASH on that profile. And there were 3 or 4 presentations on weight loss. So I share that this networking between fields is just going to lead to better care. And for a problem that continues to grow, just to give you a number, currently 42% of Americans are obese. And by 2030, it's going to be 49.5%. So 1 out of every other person in the United States will be obese. So clearly we need to do a better job. And again, we blame insurance companies that don't cover a lot of the care needed. That will have to change. We're in a paradigm change, at least for the deficiency we see of taking care of patients in the United States. I don't know if in England you have better coverage for weight loss medication, structured weight loss programs. How does it work in England?
If I'm going to say what surprised me most, I'm going to take it back because I wasn't here yesterday, but I was here for Harry Rutter's state-of-the-art lecture. The focus was on people, not patients, but also that we all spend in medicine. When he did that olive, a lot of the funding, a lot of the evidence is about at the end stage game, the cost analysis and the research in the small parts of the disease. But actually the massive part of the disease is the lifestyle modification, is what we can advise. And I just thought that whole day rocked. Because we had some of the top hepatologists in the world showing research into lifestyle. So we can do it. And a Manal's session alone, just on sodas and screens, and then Jean's on sleep deprivation and the things, it was just absolutely fabulous. So going back to basics, we can do it because that affects every single person, irrespective of phenotype and the heterogeneity of the disease. Actually, what we targeted on Wednesday fits everybody. The research that we do is very, very specific into the small groups. So again, that whole olive that Harry Rutter described, that just blew me away. So I really enjoyed that. And that was carried on today into primary care. It was a shame that despite that, there was very, very few people at the primary care session about how GPs and we could manage it better. So that was a bit disappointing following Wednesday, but totally rocked on Wednesday.
I think another thing that came out of this meeting was really the nuances from a public health standpoint. I mean, yesterday we saw how food insecurity is a major risk factor, and early food deprivation or the sensation of potential food deprivation plays a role in the acquisition and risk of NAFLD and NASH. And we also heard the impact of just having NAFLD and NASH on the risk of one even being on a ventilator if you were to acquire COVID, let alone the heightened risk of potential morbidity and mortality. So what came out to me yesterday is the public health footprint beyond the biology of organ-based disease on access to food, access to early vaccination, and priorities from a public health standpoint that really need to be focused. I mean, when we rolled out vaccines for COVID here, it was age-based. It wasn't priority disease-based comorbidities. If you were over the age of 65, you had priority. But the data that was presented yesterday suggests that comorbidities are just as important a driving factor that weren't considered when we rolled out vaccination strategies.
I think that's fair. Let me wrap up the icebreaker and then we'll dive into the meeting. And I'm sure we'll get back to all this stuff because the papers people are talking about and because of what the day was. I've been impressed by the whole tapestry. First of all, I think hats off to Easel for doing the food insecurity session. Actually, Louise, the food insecurity talk Ani Kardashian gave in the general session yesterday was the one where I knew you'd be fist pumping. And go back and take a look at it. And then the talk today from South America about the impact of alcohol reduction legislation and administrative rules and how that affects everything ranging from how many traffic fatalities you have to the health of the population. And almost that it doesn't matter exactly what you do. It matters that you do something and get people's attention on it. I suspect that a lot of the rules, however, have to do with the age at which people can start drinking. And that raising the drinking age in countries where people think it's okay to drink at 12 and drive at 13, that might be a good thing to elevate all that. That said, at the same time that's going on, we start to take a look at the idea that, as Manal said, and not only in the context of COVID, but in the context of fatty liver disease, the comorbidities are the issue. And as we start to think about what we're treating here, we get away from that. Yesterday on the podcast, and we'll come back to this a little later maybe, we talked about the idea that the NASH drugs are not statins, by which I mean that 20 years ago, when the statins showed up in the 80s, health insurers in the States went crazy because it was $25 billion a year spent for a 20-year benefit when no one was going to be covered by them and half were going to be on Medicare anyway. And you couldn't really tell who to cover, except based on what their cholesterol profile was. Here, patients with F3 or F4 have one kind of risk. Metabolic risk is not necessarily correlated to fibrosis level, but is correlated to things you can measure. And when you get to things like the importance of insulin resistance, you know that even if you don't have NASH drugs, you can start to look at NASH patients and treat them better by looking at drugs that are available and comorbidities that they have if you think more holistically about the patient. So I just keep thinking this is a richer tapestry. It's like every hour my jaw drops at least once. And that's been what it's been dropping on. And with that, why don't we go on to today's topics? In advance, I've asked everybody to pick one paper they're going to spend 5 or 6 minutes talking about, and then we'll go into conversation. If you listen to where we've started so far, you can tell this might get a little far-ranging, and that might be fun. And then you folks are invited to come in with questions whenever you're ready, if you're in a live audience. So who wants to start?
I can start, or ladies first, or Manal, you lift your hand there. I mean, whatever.
I am happy to give the platform to Ken. We have missed his presence in sessions past, so by all means, Ken, you take the stage.
Okay, well, the paper that I was asked to review was the one on lanifibranor, on changes in lipid metabolism, cardiometabolic profile and liver injury, fibrosis. So for the audience who's not been familiar with the NATIVE study that was presented last year, what lanifibranor, the key trial that they reported was in 247 patients that about half had type 2 diabetes, and they divided in 3 groups of lanifibranor 800 milligrams a day. I would have to say, again, backing up a little bit, lanifibranor is a PPAR alpha that has more effect on lipids, gamma, which has effects on adipose tissue, insulin sensitivity, and glucose metabolism, and delta, which is a little bit of a mystery exactly what it does in humans, but presumably improves inflammation and fibrosis in the liver. So this pan-PPAR has the potential to hit several targets in NASH. So in this key study, they recruited 247 patients. Of interest, 76% had moderate to advanced fibrosis, F2, F3. They excluded F4s, and they basically showed something very, very interesting, which was the ability to meet the histological endpoint. So in a summary of a lot of information, I'm just going to report on the higher dose. With the higher dose, about 44% met the endpoint of resolution of NASH without worsening of fibrosis, compared to 9% of placebo. In terms of fibrosis, they also met the endpoint, with 48% of the patients reaching the fibrosis endpoint without progression of NASH, compared to 30% of placebo. And if both endpoints together, hitting the resolution and fibrosis, happened in a third, compared to only 7%. So highly effective for NASH. But here the abstract was more focused on what else can it do? Because as the audience probably knows, more people are going to die of cardiovascular disease having F2 and F3 than from cirrhosis, from progressing to cirrhosis. So what did it do? So what they showed basically was that it improved the lipid profile of these patients, which is a big factor for cardiovascular disease. Triglycerides dropped about 20%. HDL increased. Remember, this is a 6-month trial. And what they also found was a reduction in ApoB lipoprotein and the ratio of ApoB, which is the bad lipoprotein in LDL, to APO1, which is the good lipoprotein in HDL. So improvements in lipid profile, improvements in blood pressure, particularly in diastolic blood pressure, improvements in insulin sensitivity by HOMA. They also included some markers of fibrosis, which are nice, but again, you already have the histological endpoint. They showed there's improvements in something called MAC3, they mentioned, which is a mixture of HOMA with CK18 and AST, and in TIMP1, which is another marker, and MMP2, markers of inflammation and fibrosis, and reduction in CRP, which again, it's a kind of a general marker of inflammation. But again, when fat goes down in the liver, CRP also goes down. So it's not only coming from macrophages. So bottom line, a very positive cardiometabolic profile, and together with histological endpoints. And that's the key finding of this study. I have a couple of specific thoughts about it. Number one, I think this is going to be a very attractive compound if these results are reproducible in their larger phase 3 studies. Number one, I think it blurs or completely changes the paradigm we hear in all meetings that we need to have a metabolic or an antifibrotic medication. The improvement in fibrosis has been larger than with any antifibrotic, greater than any FXR, greater than any other drug or any other mechanism of action. So it proves that a metabolic drug can significantly improve fibrosis. The delta has been valuable. And again, this is an important thing, because I think that the second important thing for patients is it is difficult to have a drug given to a patient just for the liver, on top of the medication they're taking for diabetes, for lipids. So I think a drug that has added value like this one, or you can say other diabetes medications like semaglutide, will be very valuable, because people and payers are going to find more than one benefit. So that's a strategic advantage that drugs that improve the cardiometabolic profile are going to have. And finally, the drug was overall very safe. There was a weight gain of an average 2 kilos on the lower dose and 2.6 or 7 on the higher dose, which is in line with some might have remembered the Sirius compound and with pioglitazone, which is, again, something we don't want, but we know that PPAR gamma lowers visceral fat. I just learned yesterday we got a paper accepted looking at how pioglitazone reduces visceral fat, and that's the metabolically bad fat, and you put the fat in a compartment which is less metabolically harmful. And hopefully long-term studies are going to prove that lanifibranor, like pioglitazone, can reduce cardiovascular disease. So I think it's a very exciting finding. Unfortunately, we're going to have to wait a long time until the phase 3 is over, but it's very promising for the field.
Okay, questions, comments?
So I'll push you a bit on the cardiovascular risk. So we know that these patients are at elevated cardiovascular risk, as you say, that the risk to them is probably substantially greater in the patients who are enrolled in that particular study than a liver endpoint. In a phase 3 trial in NASH, which typically enrolls 1,000 patients, for instance, do you think that a trial of that size is going to be big enough to demonstrate cardiovascular risk reduction efficacy, or is that going to have to follow in later studies?
Well, here we go. So it is going to need larger studies. So the cardiovascular trials, for example, with pioglitazone, the initial one was called Proactive. They had 5,000 people to show reduction in stroke and reduction in myocardial infarction. More recently, the IRIS study giving, for example, I'm just trying to compare with the closest cousin, let's say, of this drug, giving it to 3,000 people without diabetes showed reduction in cardiovascular disease over 4 years. But you have to do a large trial. So the trial in a phase 3 is going to be aimed at showing liver benefit. But I think that everything else will be going in the right direction. So you don't have enough events with 1,000 people because the event rate now in people with diabetes for cardiovascular disease is between 8 to 12%. So with 1,000 people, you'll have a handful of cases. So it wouldn't be enough. So answering your question, no, but you will be able to confirm in a larger population the lipid changes, blood pressure changes, and more importantly, we want to see if it is going to meet the NASH endpoints, which is really what people are looking for.
And I think to speak to Ken's point and to kind of address Ian's point a little bit, seeing, at least an improvement in cardiovascular risk is really encouraging for any therapeutic. And so that's just an added feather in the cap, because the FDA is going to ensure they take a stand that they're not going to approve any drug at the expense of cardiovascular disease. So we at least want to be cardiac neutral, if not strive to decrease all-cause morbidity and mortality, understanding that cardiovascular disease is overall the leading cause of patients. So this is an important issue that we'll ultimately drill down to. But I personally don't think we're going to be able to have the huge cardiovascular size registration type trials to prove therapeutic efficacy and from a cardiovascular outcome standpoint, as long as receiving no danger signals in the context of NASH trials and getting a decrease in cardiovascular risk profiling overall.
Yeah, the FDA has removed the need for cardiovascular trials in diabetes medications because what has happened is that it really inhibits the risk of developing new drugs because you have to do a $400 million cardiovascular trial. But we've learned from it. And again, we won't, considering the difficulties doing a biopsy study, it's not as simple as a cardiovascular trial. But it's a great question. We would love them to later on take that challenge,
Because the thought I had when you said large study is not only large, but long, right? If you get 20,000 people for 6 months, you haven't accomplished anything. So it really has to go in both directions. And the FDA, the whole idea of clinical endpoints recognizes the idea that we may not have enough time to prove the mortality and morbidity impact of these drugs before we want to approve them.
In addition, remember that you're in the background of statin therapy because you can't use a placebo anymore, right? So for a good reason. So just to give an idea, for a drug that reduced LDL about 20%, that is ezetimibe, they had to recruit 18,000 people for 4 or 5 years in the IMPROVE-IT trial to show a benefit after acute people who had already in secondary prevention. So you can understand the magnitude of that undertaking to do this. It's a great question, Ian, but challenging to definitely prove.
Other questions about Lani? There were actually 2 Lani papers today, and Ken is really, you talked about one of them, but you're touching on the point of the other one as well, because that was fundamentally the whole idea was to fill in the profile and take out the F1s.
Yeah. So again, they also showed a slide including the F1s, and histological results are pretty much about the same. Now, you have to say that that's the key, because we already know from fibrates and from PIO what the metabolic benefits are going to be. The question is the histology, right? We're in the NASH field, and the results have been the best so far for any drug. So I do think that this is finally going to move the PPARs into the landscape, which I know my peer hepatologists have been a little bit hesitant to use. But again, remember that you can also, because of the weight gain, but what many times is missed is that the weight gain with PIO or lanifibranor of 2 or 3% is associated with converting somebody from being metabolically very unhealthy to metabolically healthy. It is completely opposite to any weight gain by overnutrition. With weight gain with PPARs, particularly PPAR gammas, you reduce the chance of cardiovascular events, you improve insulin sensitivity, and you decrease the progression from prediabetes to diabetes, all the opposite that you do when you regularly gain weight. On top of it, we have another great drug I think we're going to be talking about today, semaglutide, right? So in the diabetes field, we combine these drugs and you have a net weight loss when you combine these drugs. So in the end, I think that we have now two powerful drugs, or we will have lanifibranor and semaglutide with a NASH indication that are going to really completely freeze steatohepatitis. And with that, in addition to having a good chance of reversal, for sure there's not going to be progression. So, and again, this debate between antifibrotics and not, I think is going to dissipate, because as you know from the New England paper by Dr. Newsom in November last year, 48% of the patients had reversal of fibrosis compared to 30% of placebo. So there was also some antifibrotic effect. So I think that the additive effect will definitely change the natural history of the disease.
So, Ken, I'm laughing when I'm listening to you. I'm about to prove how old I am. In 2002, 2003, one of the top 10 drug companies in the world that had a huge developmental PPAR franchise asked us to go model out how to find a home for it in diabetes. And we couldn't do it. The pure performance against glycohemoglobin just wasn't good enough, probably to get approved, certainly not good enough to find a home against what was available at that point in time. So when I hear an endocrinologist, a guy who spends a lot of time in fatty liver, but an endocrinologist, talking excitedly about finding a home for PPARs, I'm thinking that right now PPARs have been wandering in the desert only half as long as my people. My people wandered for 40 years. They've been wandering for 20. Right?
Everything comes back, and I still think it's going to take another generation of clinicians, not only endocrinologists, to fully adopt it, because the bias and perceptions against PPARs is still strong. People still think in rosiglitazone, which is a pure PPAR gamma that had no effect in NASH, it just reduced fat, and don't really see it yet with pioglitazone or this improved version that we can call lanifibranor. But I think it's a matter of time. Big breakthroughs take decades sometimes.
Okay, here's what I'm going to do. I'm going to violate my brave one go next rule, and I'm going to do exactly what Ken did and said, why don't we just shift from Lanny over to Sema? A, because they're sitting next to each other on my screen, and B, because it seems like a natural thing to do. Manal, why don't you go ahead? Audience, if you're trying to ask questions and you're not getting in, send me a LinkedIn message, and I will, because I'm looking on LinkedIn as we go along. And if you have questions you want, we'll get them in, even if we can't figure out how to get you to the screen to ask them. But Manal, why don't you go ahead with Sema right now?
I chose the abstract that was presented by Dr. Sven Frank, which was a subgroup analysis from the semaglutide study for NASH. This was a randomized placebo-controlled trial that was done by Dr. Phil Newsom and has been published in the New England Journal of Medicine in November of last year. And what this abstract drove to do is really drill down into that data and assess in the entire cohort whether there were any unique predictors for a treatment response. And just to recap that study design, what was evaluated was 3 different doses of semaglutide, 0.1, 0.2, and 0.4 compared to placebo. It enrolled 320 patients that had biopsy-driven NASH at baseline with at least stage 1 to 3 fibrosis, and did a liver biopsy at week 72, the primary endpoint being resolution of NASH with no worsening of fibrosis, and the secondary endpoint being improvement in fibrosis with no worsening of NASH. And that semaglutide study demonstrated that overall, semaglutide at the 0.4 milligrams was effective in NASH resolution. And so what this abstract had carried it one step further to really evaluate if you stratified patients out into a harder to treat cohort of patients with stage 2 and 3 fibrosis at baseline, was the performance of semaglutide any different than all the patients that were randomized? And interestingly, semaglutide performed no differently if you did the subgroup analysis strictly for patients with what I call significant, what the field calls is significant hepatic fibrosis, stage 2 or higher. And also that held true for the improvement in fibrosis, that it was as effective compared to all randomized patients. And the subgroup analysis stood the test of time, that age, presence of diabetes, gender, BMI, irrespective of these potential confounding variables, semaglutide, the effect of semaglutide on NASH resolution held out, which would suggest to me that, as Ken was alluding to here, that SEMA probably has broad applicability across populations at risk, independent of these unique risk factors. Presence or absence of diabetes, yes or no, it'll work. Presence or absence of stage 2 or 3 fibrosis compared to stage 1, it'll work as effectively. Male or female, it'll work as effectively. So it does, in my opinion, create that potential foundational therapeutic benefit in the landscape of probably emerging combination therapies in the future. And we will, to Ken's point, combine a PPAR with SEMA, but it also states that we could potentially combine SEMA with many other emerging therapies in the treatment landscape right now. So this subgroup analysis drilled home the fact that there was no pre-treatment predictor that blunted that therapeutic response of SEMA in NASH resolution.
And if I may comment, I mean, those negative studies that are important because it improved whether you had or didn't have diabetes, whether your BMI was below 30, so it would help for the overweight group of patients too, or all the way up. It helped by gender. Basically, and as a diabetologist, we used a weekly lower dose for quite a while that goes up to 1 milligram. And the weight loss in those studies is about 12%, similar to the daily injection dose that we work in this study with Dr. Newsom in the New England. And this is important because, as you may have heard, the FDA approved a 2.4 milligram dose, which is equivalent to the max dose of the daily injection used in the NASH trial for the treatment of obesity on June 4th. So this is based on 4 studies that were published in February and March of this year in JAMA, New England, and others. So now we have a drug. And so just for the audience, there are no FDA-approved drugs. The approval for NASH will take a while as a phase 3 study is just starting. But there is a choice today to treat obesity in individuals without diabetes with the weekly formulation, and the option to treat people with diabetes and obesity also. And what I tell my fellow endocrinologists, if you have diabetes, and I hope that they're going to start screening more efficiently for NASH with FIB4 and imaging, elastography or shear wave. If you find NASH in your patient with diabetes, now, even without diabetes, with semaglutide to treat obesity or semaglutide to treat the diabetes, you could help these individuals prevent the progression of disease within indication-related disease that probably is a driver of NASH. So very useful data for us as clinicians.
And it speaks to SEMA can really blunt the metabolic drivers broadly based on its mechanism of action, the driver of insulin resistance and optimizing insulin sensitivity.
What I'm hearing is a perspective that goes, GLPs are not just for diabetes anymore. Basically, you don't have to have diabetes just to be a drug you might want to give somebody.
Correct. And I use it, and I would have to say that you titrate slowly, even slower than in the clinical trials, but there's a forced titration somehow in the clinical trials. So you treat a chronic disease, we keep it at the dose that the patient can tolerate, and it's usually well tolerated. And I hope hepatologists become experts as we are. And the only major limitation is that the semaglutide is terribly expensive. For example, I work in the VA system, and the cost of treating somebody with semaglutide is I could treat 60 people with pioglitazone or other oral agents for diabetes. So cost is an issue, but beyond that, I mean, it's a drug with usually very good acceptance.
So Ian, you look like you have a question, because I have one, but I'm going to defer to you.
Yeah, well, so I've got a comment, and it was about what Ken asked me right at the beginning about how we manage weight loss and weight loss medications in the NHS. And I have to take a step back from that and say that for the management of diabetes, then the GLP-1 receptor agonists are in third line because of the cost. And so for weight loss treatment, it's going to be the same. They're going to be highly restricted, I think. And the question then about these medications that have benefits on the whole of the patient, it comes down to at what point in the patient's journey does liver disease become the indication for treatment? In the diabetic patient, elevated cardiovascular risk, then their risks of non-hepatic mortality, morbidity are much greater than they are from liver disease, perhaps probably until they've got cirrhosis. So at what point do we think that these are drugs for liver disease, and at what point do we think that these are drugs for the whole of the rest of the patient's phenotype?
U.S. payers are asking exactly the same question. When they think about fatty liver drugs, they're less excited by these secondary benefits. They say, we've got ways to treat that, and more focused on, okay, exactly what are you going to do for NASH, which creates a couple of challenges that I may come back to, although it's not what my paper is about. I do believe, though, that with good enough outcome studies, we may have success in stratifying how people think about fatty liver patients so that it's a more holistic and metabolic view. And if that were the case, then what you might see, if not in the NHS in the States, is that there are patients for whom GLP-1s would be stepped forward earlier into therapy or approved earlier into therapy with fewer steps, because it might be a way to address a couple of issues at once.
Yeah, so how I think the field is going to evolve is as follows. I think the field will adopt screening for liver fibrosis in all patients with type 2 diabetes. And I think that will be the case because if we use the FIB4, there is no cost to do that. Secondly, we would not think about the patient with fatty liver because we know now 70% of people with type 2 diabetes have a fatty liver. So that is not really the issue. The issue is if they have fibrosis. And in the same way as when we identify the person with diabetes and NASH with fibrosis, calling it F2 and higher, we will choose a drug that is showing efficacy in that. So in the United States, if you want to talk about cost, pioglitazone costs cents in the VA system, costs 8 cents. So you can treat for $2.40 somebody, lower the A1C 1%, improve lipids, et cetera, Or you can choose semaglutide if they have cardiovascular disease or a certain BMI. And again, the cost when these drugs are given in big healthcare systems, I think like NHS, will be much lower. And I think the issue will be looking at a 16% weight loss, as you see in obesity trials, or 12% weight loss in the greater benefit that these people can achieve. So I think as you look at the boxes for treatment of diabetes, that if you have chronic kidney disease, you use an SGLT2 inhibitor. If you have NASH and diabetes, you use maybe the cheap option would be pioglitazone and the more expensive one, semaglutide or something like that.
When we come back to multi-specialty later, because Louise's talk is going to get to the role of primary care physicians, I want to think about what happens when primary care physicians have to, if they're going to have to pull a patient through semotherapy. Obviously easier to take one pill a day and not have noticeable side effects than to deal with needles and the possibility of a period of gastric discomfort. So when you operate in that world, I think maybe the balance starts to shift a little bit. But we'll see, and we'll talk about it. Right now, I figure we might as well, since we wound up, Ken, you showed up and we wound up with a day of diabetes drugs. Ian, why don't you talk about your topic?
By all means, it's wonderful that Ken's here, really, because I'm going to talk about canagliflozin and the potential liver benefits of that drug in the CANVAS program. So this is work that's been done from Switzerland by Dr. Ibrahimi, and they've got data from the whole of the program that's held in a public data resource called the YODA Project, which is terrific because it allows researchers to go and get access to the full clinical study reports so that they can analyze all of the data, the primary data from those trials. So they get all 10,000 patients in the CANVAS program. So that's in CANVAS and CANVAS-R, so the cardiovascular and renal outcome studies. And they analyze their baseline characteristics and then look to see what happens. And there are a few interesting observations, I think, in the baseline characteristics. So the HbA1c is between 7 to 10% in a population who's in their 60s who've had diabetes typically for more than 10 years. The proportion of patients with an elevated ALT over 30 is 27%, yet less than 10% have a diagnosis of steatosis, and a much, much smaller proportion have what they termed hepatopathy. And that speaks to the low rate of diagnosis of NAFLD in a diabetes managed population. And what they didn't say, although I asked them, if you look at the SAE data in those studies, the number of actual liver events is tiny. It's a handful over a 2.5-year study, which, as you've just said, 60% of the population will have NAFLD, and 60 60 with established cardiovascular disease. So it's likely that there will be a significant number, measured in the hundreds, I think, who've got cirrhosis within that population. So to see very few events is interesting. And I guess that's one of the reasons why when we talk to diabetologists in the UK, often there's quite a lot of pushback and say, well, we don't see complications of liver disease very frequently or hardly at all even. And that's difficult because we're seeing it all of the time in our clinics. But in terms of the outcomes in the study, they report significant weight loss. So in those patients treated with canagliflozin, 23% had a greater than 7% weight loss, which would be associated with histological benefit in patients who had confirmed NASH, which is obviously a major benefit to treatment and similar, not the same as, but similar to that seen in treatment with SEMA. And then if you look at improvements in ALT, then over a third of patients who had an abnormal ALT was reduced by 30% or normalized. And that really speaks to the benefits of weight loss in terms of improvements in liver, and it sort of provides some confirmation that there is likely to be an impact of treatment on the patient. What they didn't present was evidence relating to changes in non-invasive scores. So I think they were able to calculate FIB4 for at least some of the participants, but none of that data was presented. So it's not clear whether there is evidence of benefit against fibrosis, but in a largely low fibrosis population, it might be quite difficult to demonstrate that. But I think it's useful to think about drugs that maybe Ken will know, but drugs that it doesn't look like will be developed for NASH because they've got new indications that have extended the life of those drugs. So I can't see that they will be pursuing studies in the way that the studies are being pursued for semaglutide. So they're probably drugs that would be available for use with potential benefits in terms of reducing progression of liver disease, but with associated continued benefits in that population with ongoing cardiometabolic multimorbidity.
Which study were we talking about yesterday that showed real links between kidney disease and liver disease? I know there was one, because I can visualize the tables, and I'm not remembering what study it was because there's a lot flying around my brain.
There was a large study from the Optum database. Was that the one? That study's a bit difficult, I think, because I couldn't figure out what was incident and what was prevalent disease and how often people were counted in the numbers. It was really quite tricky. And I guess there will be counting of patients who've got identified with NASH because an identification of them because of their comorbidities. So there'll be some reverse causation between fatty liver disease and kidney outcomes. But that doesn't mean that the SGLT2s wouldn't be useful in that context. Gives good evidence to support their use, if anything.
Yeah, that's what I was thinking. Go ahead, Ken, you're nodding.
Yeah, well, I want to put a little bit of context. So this database, so SGLT2 inhibitors have been, very promising in the diabetes field because of their cardiovascular and particularly renal benefit. Now, the drug caused modest weight loss. And again, 36% had an improvement, but 26% on the placebo. So the effect is small. But again, thinking a little bit of what you said about primary care doctors, it's the same problem with endocrinologists. We don't see people with end-stage liver disease. But again, this year in the United States, we published a paper from patients recruited in primary care, family medicine, and endocrine clinics, and 21% had some degree of fibrosis. And if you took F2s to F4s, it was 15%. Now, the interesting thing is that 90% had normal liver enzymes below 40, right? And if you took below 30, still it was about 70 to 80%. So liver enzymes are not going to be the right way to address this. We don't see them with cirrhosis and ascites because once they get so sick, they go from the hospital to the hepatologist, maybe the primary care, but they don't come anymore to our clinic. It's like saying, I don't believe that diabetes causes chronic kidney disease because once they're in hemodialysis, I don't see them anymore. They go from the dialysis center to the nephrologist, and that's what happens. That is going to change as we screen better. Now, regarding canagliflozin, we published a study in diabetes, obesity, and metabolism in 2018. We recruited 56 patients that we treated with canagliflozin, and we looked at insulin sensitivity, liver fat by MRI. And what Cana does, it reduces liver fat about 40%, about 20% against placebo, and improves a little bit hepatic insulin sensitivity. But it's a modest effect. Others like empagliflozin and dapagliflozin have had similar results. I think it's too little an effect to have an effect on histology. There are no biopsy studies yet, but it will definitely help to lose a little bit of weight, lose a little bit of fat, and combine with the other drugs in the pipeline. So I think they're going to play an additive role, and definitely we are very fond of them in the diabetes field.
Other thoughts or comments? before we go on to Louise? So now we're going to shift out of diabetes drugs, and we're going to go to, the role of primary care physicians in the entire process, which is not entirely unrelated to thinking about diabetes drugs in the context of NASH. Although I don't know that has anything to do with your paper per se. Go ahead.
Just going to shift completely, as you say, to primary care. There was a couple of interesting sessions this morning in primary care. One of them, the one I'm particularly going to cover, is by Dr. Mead Matthews, which was improving outcomes in liver disease, the role of the primary care physician. And she did this work with Professor Nick Sharon and Janisha Patel between 2016 and 2019 within a pilot St. Mary's surgery down in Southampton area. And then it developed further out. But it seemed to come about because despite all of the referrals from primary care, only 10% of patients were turning up in a secondary care setting. So what they did was they basically added a liver specialist nurse in with FibroScan to look at direct access to some extent for FibroScan. Mainly to educate the primary care physicians, to also talk about liver health and lifestyle and get it into a more local facility, and to just generally open that topic by the sound of what she was discussing. So they looked at primarily education about why liver was important, combined with convincing them that GPs could do something about it rather than just transferring to secondary care. That instead of repeating liver blood tests, they could think about their patients once every 3 years. I probably still question that when we know that we can get fast progressors and slow progressors, but this was the study that they were doing. They made it simple with 5 courses, 1 plan on a page, and they gave them access to tools, ELF, which obviously is an enhanced blood assessment, and FibroScan, which they'd never had access to before. It was always in the secondary area. So they integrate it into their own clinical system. Basically, it's based on all of the figures that British Liver Trust and everybody produced, that liver disease, they showed them how much liver disease against any other profile was increasing in the UK. They also looked at when the patients in their area were dying. The vast majority of patients who die have never seen or had an outpatient appointment. Very few of them had had one within 30 days. As they got further and further down the scale, most of them hadn't even had one in 1 year. So we know liver patients present late. So they were giving and facing the GPs and primary care physicians with all the evidence that these patients could be found and in their practice and actually be saved. So they really focused on 5 causes of cirrhosis: alcohol, non-alcoholic fatty liver disease, viral hepatitis, and the treatment, autoimmune metabolic treatments, and miscellaneous and cryptogenic. So they discussed the 3 stages to liver disease and the outcomes test: normal livers, the liver warning signs, progressive fibrosis, and cirrhosis. So they tried to basically keep it as simple as possible. Looking for patients out of the pathway was basically high risk based on the risk factors, not just on blood tests, focusing away from the fact that an abnormal blood test doesn't confirm liver disease, but neither does a normal blood test take away the fact of liver disease. So providing enough information for the GP to be encouraged and empowered, letting them believe and really know that they can make a difference to their patients in all different areas. So as I say, they integrated it into the clinical system day-to-day use. Alerts were added to the liver conversations so that if a patient presented who'd had a previous result, bad liver function tests, or they'd had previous coding for liver disease, even if they were presenting with something else, what they did was have a conversation about liver and liver health. So they were really pinpointing. They had 3 basic entries into the system, which was abnormal liver function tests, drinking hazardly, or absolutely if you were a known drinker. So they really signposted this. If the audit scores came up, if their ALK phosphamine over 140 in the last year, or ALT above 180, so by integrating this into the pathway, it allows the physician to see these patients and pick them up and detect them quite early. So it was an AI system approach in the back. But I wasn't sure when I looked at that whether or not there was anything that was suggestive that they were doing this with obesity, type 2 diabetes, and medications linked like methotrexate, tamoxifen, postmenopausal women. So they split the pathways into drinkers and non-drinkers, and these pathways are available online, and they were improving the facilities for that. And I think what was key out of it was the increase in FibroScan access did directly lead to a reduction in referrals into secondary care. But arguably, I would suggest it probably led to a greater pickup of those that GPs could manage, but I didn't see the breakdown of that. So I thought it was an excellent process. The pathway is available online, and I think it proves that giving primary care physicians direct access to FibroScan really benefits their practice.
So, questions or comments for Louise?
I mean, just one comment, really, and I've been discussing this on and off with colleagues over the last little while, but as hepatologists, we have made hepatology look fantastically complicated, and that's despite not really having any very good medicines, apart from for treating viral hepatitis. And there's a sort of mystique that surrounds the specialty, which in some ways suits us quite nicely, but it doesn't suit transfer of our expertise and simplifying the way that we manage patients into primary care to allow patients who've got significant disease to be identified and for appropriate treatments to be started. And those treatments are not that complicated. Reducing, stopping drinking, interventions to improve activity and to reduce body weight, and for management of comorbidities. It's our responsibility as specialist hepatologists to simplify it, make it more straightforward so that it can be accessed much more easily in primary care and in associated specialist clinics.
Do you think it's more that we make it complicated, or everybody gets scared about the liver? Because it is way complicated. It is difficult, and it's easier to just hand it over. The one thing that did surprise me in the figures, and I don't know whether the breakdown that they could produce from Southampton, whether or not when you put a nurse specialist in who's got liver knowledge, I would have thought you see a better pickup of and more patients being, and there were significantly more patients scanned, but the plateau of referral rate in the context that you're now scanning more people, the diabetic population, you're enhancing the knowledge of who to scan, those on drugs like methotrexate, postmenopausal women. So you open up the spectrum of more people in primary care that could have a liver condition, but you can manage them better. And then when they, rather than make it too scary, because I think you're right, we've got lots of complicated pathways, usually based on a blood test marker, and the liver's not designed to show us it's under stress. So therefore it makes it even more complicated, because we can't tell if it's damaged with a bad blood test, we can't tell it's not damaged with a good blood test.
I have a slightly different view, Ian. I don't know that it's complicated as much as it is still in its naivete as a field. In other words, when I reflect back, and I had the privilege of listening to the Nobel laureates who have since solved all our problems with hepatitis C, but when you hear about the early days of trying to develop a simple biomarker for hep C and differentiate predictors of treat response and assessing an efficacy endpoint, and let alone nobody wanted to touch interferon and ribavirin because it was just complicated and had a lot of side effects. And then as the field matured, we got to a point where we had deliverables that could be readily applied to primary care and infectious disease and other things. I just think we are, in parallel with the whole hepatitis C journey, relatively still young as a field, despite having been in it for 20 years, 25 years, relatively still young. And I think in the upcoming 5 to 10, certainly we're going to mature in our therapeutics and diagnostics and non-invasive approaches to NAFLD and NASH, where we will have deliverables to render for the broader use and applicability. So it is complex right now, but I think every disease in its infancy is, in a sense, until the science and the therapeutics and the discovery matures fast enough that it's easily understandable for the broader disciplines within medicine.
So listen, this is a fantastic discussion. We have an audience question waiting. I haven't gone yet, and we're an hour and 10 minutes in. So I want to make a comment, maybe get a couple of responses to that. And this is to what Manal just said, and then I want to go to the audience question and then different direction. I'm struck by the idea that primary care is just about everywhere is overwhelmed. Every field of medicine is moving faster than they can keep up. And the paperwork and regulatory demands on them, which take different forms in different markets, but are true virtually everywhere, eat up increasing amounts of their time. And 5 years ago, if you did studies in the U.S. and asked doctors what they liked least about their practice, they'd say it was fights between staff members. So there are all these things going on that aren't why anybody came to practice medicine. So what might be complicated to a primary care doc whose daily plate is about yay high might look really simple to us. And my concern would be about the rate of adoption of information in a primary care setting. The flip side of that is if we teach them to identify the problem and then push them on, and we don't have a massive influx of hepatologists and endocrinologists, they're simply going to bottleneck in a different place. So there are some really interesting challenges around the logistics of how you make all this work.
There's two factors that drive the practice of medicine. Yes, there's altruism for those that go into medicine, but ultimately what drives practice is time and money or resources. It's been shown that if you develop quality metrics or incentivized based on reimbursement, that drives clinical practice. There's no incentive to care for, or was no incentive to care for complex Hep C patients in lieu of performing sometimes endoscopy. And until we develop valued metrics for ensuring that we screened all baby boomers and documented it, and there was a reimbursement metrics based on quality. And ultimately, I think the same would apply to what our primary care physicians are going through, and all physicians, I believe. Things have to be tangible, they have to be understandable, they have to be reimbursed, and there has to be the appropriate time by which to render quality care. And granted, I think there are metrics along this line where our system is broken, and we need public health specialists, and we need our legislation to get involved and unencumber the practice of medicine in such a way that we can deliver quality, affordable health care in our country.
Yeah, that meant Stephen actually, Manal, a couple of weeks ago on the podcast, used a 5-letter word that had never been used before, actually an acronym, which is HEDIS. And for those outside the U.S., that is the process by which you get quality metrics into how care is evaluated in the U.S. I agree with that. I just think it's going to be a longer and thornier path than we'd like to think. With that, I'm going to go to Shardul Jain, who's calling in with the following question. I'm going to hit the green button, and then you're going to be on the podcast. So hold on one second. So let me ask you, before you answer your question, where are you located right now?
I'm in Boston, Massachusetts.
Okay, so you're in a perfectly reasonable time zone. Congratulations.
Before I begin, I just want to thank you, Roger, Louise, Manal. I've been an avid listener of Surfing NASH, and my background is in pharmaceutical sciences, and I'm working as a director of R&D at Ultrix Bio. We are a small startup company in Cambridge, and we have developed a polymer-based solution that can coat the duodenal surface and works basically like a surgery in a pill. We are very excited about what it entails for people suffering with diabetes, but not only that, we are actively now testing our drug solution in NAFLD and NASH patients, and hopefully it'll bring another treatment, if you can call it, in the armamentarium of other options that are available, just like semaglutide is. And listening over to your podcast over several episodes, I'm really intrigued by the fact that unmet need in this field is fibrosis, as you guys have outlined very, very, very elegantly. And I've always struggled with this question as to when we look into solid tumors, we have drugs, maybe these are MMP inhibitors or other drugs like beclizumab that have been used to loosen up the tumor fibrosis or extracellular matrix for enhancing the drug penetration, whether it's nanoparticles, liposomes, or even other antibodies. How come that fibrotic matrix, is it any different to what fibrosis is in liver? And if not, then why can't those drugs be part of anti-fibrotic treatment armamentarium?
I think I can try and address this. I do agree. I mean, ultimately, the primary predictor of any outcome is going to be fibrosis, which does translate into cancer. And what's interesting is all of the anti-metabolic drugs that we've talked about and experienced, short of lanifibranor right now, has met a fibrosis endpoint. Now, it's still an early phase 2b study, and it'll need to be confirmed broadly. But whether it be metformin or even straight pioglitazone or even semaglutide, we have yet to really achieve strong anti-fibrotic endpoints with anti-metabolic drugs for the most part alone. But we're also met with the challenges in how we grade, how we stage fibrosis using ordinal and categorical variables. And I suspect as we measure using artificial intelligence platforms such as AI or PathAI, we will be able to translate that more onto a continuous variable and be able to look at nuances of fibrosis regression to be able to bring some meaningful understanding to these metabolic therapies. But ultimately, we're still immature enough that our trials are only 24 weeks long or 48 or 72 weeks long, that by punting the extreme inflammatory drivers, we haven't allowed ourselves the time yet for duration to see an anti-fibrotic endpoint. We see signals there, but they haven't really translated into tangible, meaningful outcomes yet. And I think the time that will come. But we just need to be patient with the time and the allowance of the artificial intelligence platforms to validate what we see.
Now, I agree with that. I think there's one other thing I was thinking as I was listening, which is if you go back in Hep C 10 or 12 years, you have what was described as a significant number of warehoused patients with very severe disease who needed immediate treatment. Over time, as you treat more patients, as costs come down and sophistication goes up, disease gets captured earlier, fewer patients achieve that level or reach that level of urgency. That's hardly an achievement. I think if you look at NASH right now, we probably have a disproportionate number of F3s and F4s because we haven't known how to treat and we haven't been able to diagnose and capture. So in the early stages, at least, of NASH therapy, I believe we're going to have room for acute drugs that are very, very fast antifibrotics. I don't know exactly what Stephen's going to show about Akero tomorrow during the late breaker, but he referenced it in the pre as saying, look, it's embargoed, but it's interesting. You're going to want to see it. So if we can get some drugs that get fast action when people are at, compensated cirrhosis or maybe late F3, then in fact, we'll start to see that warehouse shrink, and then the therapy will shift more in the direction you're talking about. Continuous variables, multiple dimensions, holistic patients. I think right now we got two issues, and the urgent is kind of pushing out the serious a little bit. Well, thank you, and thanks for coming on. I'm going to release you now, and we're going to go back, but that was great. And if anybody else has a question, now that we know how this works, we can do it again. Apologies to audience. We're now an hour and 15 minutes in, so I'm going to do what I did yesterday and make mine very quick because I don't think I need to go through all the numbers. I wound up looking at one of the two. Ken talked about his session where 4 of the papers were about medications and the 2 in the middle were about the diet, really. And I want to talk about one of those, not the one that was about gastric sleeve, but the one that compared 2 different forms of diet, intermittent fasting, but which had a couple 500, 600 calorie days in the middle of a 20 to 2,400 calorie week versus low carb, high fat, keto kind of diet at 18 to 1,900 calories a day. They took about a small sample, 75 patients, short length of time, 12 weeks, but enough to demonstrate a 50% relative reduction in PDFF in both of the diet groups. And by the way, no imposed exercise. And the control group was given diet guidelines to follow. They just weren't pushed to follow them. Louise, this is something we talk about a lot, right? They had phone calls at weeks 4 and 8 and a visit at week 6 on a 12-week protocol. And what they were looking at primarily was what effect would it have on enzymes and on relative fat reduction. And the answer was ALT dropped like crazy, AST didn't move, and the fat reduction was compelling. Beyond that, they looked at some secondary measures, and this is where I think it kind of got interesting, okay? I don't think it's necessarily a surprise. LDL dropped more with the intermittent fasting. HDL rose with the low-carb, high-fat diet. I'm trying to remember. There were 2 differences in actual liver metabolism, Ken. One of them is that the keto diet didn't do well on liver stiffness. And I'm looking at Ian because I know you two were both there, and I don't know if you were or not. Communicated with Ian, and Ken was there. We knew that. Do you remember what the one was where keto did a little better? On a liver metric?
To be honest, I was very impressed because it boils down to the current thinking about weight loss diets, that it really doesn't matter. There have been many in the diabetes, obesity field, lots of studies comparing different kinds. And in the end, intermittent fasting or different composition diets boil down to the amount of weight loss. I mean, it really matters to what you can stick in the longer term. This is a short-term study. I think it was, right? Yeah. So what happens as you go on, intermittent fasting is harder to keep. So the thinking in the field is to use it for 3-6 months, and then go to a doable long-term diet. But again, I think for the audience, the message is pretty clear. Do the diet that you can do and that fits better your lifestyle. But in the end, it boils down to less calories, of any kind.
So Ken, one thing these guys know that you don't, unless you've been listening to the podcast more than I know, is that my wife's a health coach who works for Noom. So this is a subject we frequently have at dinner with us, all right? The issue about keto that worries me, or low carb, high fat, is that people become imperfect compliers. And as long as their weight doesn't go back up, they tell themselves they're fine. But if they imperfectly comply by adding back in sugar and processed flour and all that stuff, they may be holding their weight where they want to, but will not recognize the potential to do damage to their internal organs or undo all the good that we saw in this study. So I'm personally keto skeptic for that reason. I do agree with you.
It's a hard diet to follow long term, I would say.
And then that's the point, that really whatever you can follow long term works, but you need need to appreciate that people have to follow the diet. 80% compliance just isn't good enough for some of this stuff, even if your weight stays down.
There is intriguing data to suggest that the macronutrient composition is equally as important as calories alone, that coffee is good and soda is really bad, and the hydrogenated fats and saturated fats diets are also bad, independent of weight loss per se.
The point is that if you match for the calories, studies have shown that the amount of reduction in liver fat and most variables except LDL will lead to the same amount of liver as an endpoint improvement in liver fat. Most have been doing liver fat. So I'm very much against these unbalanced diets for the reason Roger and you mentioned. I tell my patients, forget about the word diet, choose a healthy lifestyle, love yourself. I recommend doing a Mediterranean diet. That's what I recommend. Smaller portions, Mediterranean diet. That can be done long-term, and it has the best long-term data. But in short periods of time, people have want to lose weight. And again, for short terms, it's okay to do these a little bit wild diets. But I think in the long term, you're going to have to do just a healthier, more greens kind of diet.
As a guy who's lost 100 pounds in his life, which is 50 pounds twice, but the last time was 10 years ago, and I've only put 3 of them back on since, I couldn't agree more.
What was interesting in this was the only groups that got dietary support and health and monitoring were actually the keto and the 5-in-2 diet. Those who were on the normal lifestyle diet got no help, but 18% of them, I think it was, reduced their body weight themselves. If they'd have had the same intensive follow-up, would they have got the same results with less side effects? And in fact, there were no withdrawals from the 5-in-2 diet. And I've done the 5-in-2 every now and again. I just do it as a day where I take a day where I'm not eating a load of rubbish. I don't do it as a diet, but I have done it. So it was an interesting one to watch. But if you split out normal lifestyle and don't give them the same support, you can't really compare it. So it would have been nice to have 4 arms, lifestyle with the same level of support that everybody else had had. But I think what was also interesting, whilst they commented on the fat fraction reduction, they removed those figures from the baseline results at the end of CAP and MRI. And in fact, those would have been massive levels of fat reduction. You would have seen that in FibroScan in the CAP. So I would like to see those figures because that's what we're going to be using in real life practice. We're not going to send everybody for MR, fat fraction. So to be able to utilize it in a primary care setting to see those figures at the end. So I wasn't sure why they removed. They may not have been statistically different, but you would have seen that fall.
So Louise, because people always fight the last war, let me tell you what I think that might have been. If you go back to the early days of cholesterol before LRCCPPT, there was a Scandinavian study called Mr. Fit, which blew up. And the reason it blew up was because the control group overperformed because they were given the same coaching everyone else was. So they weren't going to make that mistake again, so they made the opposite mistake. I happen to agree with you. I think that the story really is that it's the compliance and the management, because as Ken points out correctly, and Manal, I agree with you on the macronutrients, but generally, if you can keep your calories down, most of the good stuff will happen. And it's really hard to keep your calories down eating pizza all the time. So there is a certain blend to that. But so as a result, they didn't get to test the impact of the diets per se. I completely agree with you, Louise. I hadn't thought about it until you made that point, but it's like Mr. Fit in reverse, right?
Now, can I make a little comment for the audience? I think it's very important in the diabetes field. We learned it the hard way. I hope the liver field learns a little bit from our mistakes. The pat in the back and the advice of eating right doesn't work. You need to send patients, particularly with more fibrosis, or either to a structured program or to that and do some pharmacological intervention. I think in the long term, we need to begin thinking of obesity as a disease. We know that there's some differences in the way our brain function and stimulus and reward, and it's a multifactorial thing. But you should look at the obesity trial with semaglutide that called STEP 4, in which they gave the drug for 20 weeks to all of them. Then they stopped it and told them, continue doing your diet. And they continued in the other group. The control group in the next 6 months regained about 2/3 of the weight, while the other group continued to lose. So this has to be treated as we treat hypertension, we treat diabetes and NASH. It's going to be a long-term either coaching, structure program, and I think medication for most patients. I mean, that's my little two words.
So, Louise, in the tradition of this podcast, I'm going to give you the last word. Why don't you respond to agreeing with or not or both to what Ken just said?
I agree with Ken there, and I think it's vital. And I've often said that we don't put in enough psychological support early enough. We wait until, and it was made the comment, you don't get it until you're a pre-transplant. In the world of the drugs that we're looking at, and lanfibranor was discussed earlier, and most of the others, there's weight gain. If we have not addressed somebody's psychology about their own condition, when we then start to put them on drugs that do the opposite to which we talk about earlier on in their management about weight loss, that we deliberately then give them something that weight gains, how much input are we going to get? So I think we do have to be very careful early on and really, really give people support. Obesity is a disease. There's a lot of evidence from that. It's being undertaken by everything and not one size fits all. And a lot of Scandinavian populations, there's a high level of lean NAFLD in that population. And I think the BMI on this study alone average was 32, I think. So it was still quite high. So I do agree with Ken. I agree with everybody that's spoken tonight. We do need to put way more evidence in earlier in the timeline, and the lifestyle stuff from EASL this year has been absolutely superb from everybody that's commented on it.
With that, Louise does get the last word. We'll go around to the final question, okay? One thing you've seen since the beginning of this meeting that you believe will make an impression on medicine or thinking around fatty liver disease after we leave the meeting. Brave one, go first.
I would just say what we said earlier. We've been coming to, I'm probably the only endocrinologist that's been for 10 years coming to these meetings from the liver group. And I've seen a huge difference from a narrow liver-centric approach to a broader than ever now. So I do think that that's going to be the tone and the future of better care.
I think the evidence for me has been certainly the lifestyle day. We can use all of the evidence and the data about diets, changes in lifestyle, and actually put that into practice in primary care. That is where this is most powerful. And then, as Ian says, then it's for the physicians and the hepatologists to deal with the more complicated issues. But I think all of the evidence that we've been producing is just fabulous to be implemented in primary care. How? I don't know. Maybe we need multi-morbidity specialist nurses or NCD nurses or something in there doing that. But I don't know. But I think it's been great.
Well, I'll go next because it sort of follows on from what Louise said. There was an excellent session yesterday with Litmus and Liver Screen Consortia, so two EU-funded groups, focused on testing. So Litmus is about testing in NAFLD with biomarkers, and Liver Screen's about identification of disease in the community. But one of the points that was made by an epidemiologist was about a move away from validating non-invasive scores by biopsy, but really focusing on their impact on clinical outcomes. And if we can rationalize our testing, use tests that are associated with outcomes, then that will allow us to stratify patients in a more clinically obvious way in primary care. And I think that will make things a lot easier for everyone.
Yeah, I think the undertones of what was presented and percolated to the surface, that Ken's a testament to this. We've drilled in our metabolism colleagues and expertise into this disease. And the next step now is taking that crossroads with the same level of rigor scientifically and functionally with nutrition, with exercise physiologists, with behavior specialists, behavior modification and addiction specialists, with cardiologists and cardiovascular fitness and prevention. The spoke wheel is there with a few, but we really need probably many, many other spoke wheels around this disease, even public health and policy. And I think we are starting to see that percolate in the same way that 10 years ago we saw the metabolism and insulin resistance and endocrinologists starting to percolate into this, such that we can create multidisciplinary hubs of care for our patients. And that's, I think, what needs to happen.
Completely agree with all of you. I used the word tapestry back at the beginning. I'll use the same word again, that I think back just 2 years and people were trying to figure out, can we get a drug? Can we get a drug? Can we get a drug? And by the way, the drug we wanted to get wasn't going to solve most of what we're talking about today, even if we had gotten it, if you think about it. And because all the work that had been put into motion around diagnostics and around thinking about what this disease really was happened, and the urgency to treat was there, but no drugs were there, I totally agree. I think it's a much more holistic picture. And as a result, it's a more realistic picture. And I believe that the message that will come out of here is you don't have to wait. Now, resmetirom is promising, Lani is promising, Sema is here already, but you don't have to think about this in the context of drugs. You don't have to wait for drugs. But we can take big steps against this right now. particularly if we understand that where we can take action is not in the warehouse, but shutting off the road so not so many people get to the warehouse in the future. And I think if we go forth with that, we've done great. So with that, let me thank Ken for a spectacular first appearance on this podcast. Manal, Ian, Louise for always bringing it. The 5 people who were left in the audience, thanks for sticking with us to the end. And those who didn't stick with us to the end, thank you for you too. And we will be back tomorrow, a half hour earlier than today. Not to confuse everybody, but that's what we're doing. We'll be starting at 12:30 Eastern U.S. time, 6:30 Central Europe, 10 o'clock in India, 3 o'clock on the West Coast U.S. Come join us again. Now that we know how to ask and answer questions, we can really have a party. Until then, take care, stay safe, surf on. We'll see you on the podcast. Bye-bye now.
Want to join our live audience on Saturday? Go to the surfingnash.com homepage and click on the button right below our recording session dates and times. Fill out the form on the new page and provide an email address where we can send your ticket. Everyone tells us it's simple to do,